So this is part two of our discussion on the tissue response to injuries or our healing process after we've gone through an injury. And so what we're going to focus on now is some of the different responses that we get based on specific soft tissues that we're dealing with versus when we deal with bone. And bone is going to be a little different in itself. Bone's not classified as a soft tissue. We can have 4 different classifications of soft tissue. So we can have nerve, muscle, connective type tissues, and then we can get into some of the the tissues that are going to be responsible for like blood vessels, what lines our stomach, those sorts of tissues. And those, they act a little differently than the ones that we typically think about when we talk about injuries with connective and muscle, and some with the nerve, right? But bone is not classified as a soft tissue, right? It's hard, so it's not soft. So a lot of times our soft tissue adaptations, we can get different things based on the injury itself, right? And so when we think about this in terms of just muscle, right, we can have hyperplasia, right, which is more of a muscular type adaptation that I honestly don't see a lot in humans. And this is where we start to see like splitting of muscle cells into more cells, right? But what we do typically see more is something like atrophy. So instead of the cell growing, right? And when we have an injury, we can have that reduction. We talked about muscle atrophy a little bit in the previous lecture, dealing with the mechanisms of injury, right? And so we're seeing a decrease in the size of that tissue, right? And hypertrophy is a growth in the size of those tissues, specifically when we're dealing with muscle. So those are some of the ideas behind this, is that we can get normal development, we can get abnormal development, and we can get tissues that can change size, right, based on injury and stresses that are being applied to it. So it's pretty adaptable, right? Now, when we specifically look at some of these soft tissues, some are going to be much more prone to healing versus others. So cartilage is one of the ones that doesn't heal very well, and it has a very limited capacity. And this comes down to blood flow. And if we think back to our stages of healing, right? If we don't have that blood flow, or little or no direct blood flow supply, we're not going to see the inflammatory response. So we're never really going through that healing process. And so a lot of times what ends up happening is when cartilage becomes damaged, we just remove that cartilage, whether that's on a bone, whether that is, connective kind of cartilage, like a meniscus, like in the knee, like we talked about previously, right? Cartilage has a very limited capacity to heal. It's different than a lot of our other connective tissues. So when we talk about ligaments, right, a ligament is going to follow the kind of the process similar to more of our blood vessel tissues, right? We can have acute, we can have, this is where you can have a grade 2 MCL sprain and come back in 2 to 4 weeks, right? Depending on how large of a separation of tissues we've had, is because it has the ability to repair itself. Now, to go through a full healing process, it does take time. And this is where, when we have an ACL injury, or we have an MCL injury, or the Tommy John type injury, right, you can let it kind of heal on its own, but it takes a long time and it's never going to fully repair itself. And that's where we go in and we do ligament reconstructions, right? So things like an ACL reconstruction or a Tommy John surgery, or any of those types of things that we think about, we do that because it speeds up this process. And most of the time, what we are replacing that damaged ligament with is a stronger connective tissue, so that we change kind of the stress strain relationship of that tissue itself, and then we can be less prone to future injury. So when we specifically deal with this, like we said, surgically repaired ligaments tend to be stronger. Again, that's partially because of what we're using to replace it. Decreased scar formation, so it has more ability to move. And exercise ligaments are always going to be stronger, right? Versus ones that are immobilized. And the reason for that is when we think about immobilization or not being able to move, is a job of a ligament is to provide stability in the joint. So if it's not being stressed, right, if it's staying at one length because the joint isn't moving, then it's not going to be very strong. So when we talk about doing exercises for injury reduction or injury prevention and wanting to go through a full range of motion, this is one of the major reasons, right? Is that we can make that ligament stronger to then resist future injury. Now, that doesn't mean that we're always going to be able to do that, right? But that's important. And so when we go through the rehab process and that healing process, it's really important that once we get to the appropriate stage, that we start to provide stresses and provide some functional movement to a joint so that that ligament gets strong in the long run, right? And so that is definitely a factor that can affect that healing process and the time course that we go through. When we start thinking about skeletal muscle, right? And so when we start thinking about things like, a grade 3 muscle strain, right? That takes a while to repair, but it does have the ability to repair itself. It's a little bit longer time course because of the nature of that tissue, right? A ligament, its job is to support. It doesn't have a ton of movement in it, where skeletal muscle does need to move. And so to be able to get all the proper proteins back in that spot, to be able to make sure everything's working the way it needs to, we have a little bit longer time course with this. So this is where muscle strains at times. So when we do something like pull our hamstring, right, it's a long process to come back from that in comparison to just letting a ligament heal on its own for a few weeks. The healing process for skeletal muscle is a little bit longer based on just some of the properties of the muscle itself. When we injure tendons, right, this is a very dense connective tissue, right? Like we talked about before, tendons transfer force from muscle to bone, right? So when we talk about having a lot of tensile strength, means that it's very difficult to separate it. It's hard to pull or provide tension on this. Tendons usually take a bit of time. It's less than a muscle. It's more than a ligament, right? It's kind of in between. And so while similar, there is some differences, and a lot of it has to do with the tensile strength. And again, where are we on that kind of grading scale? Are we a 1, 2, or 3? Do we get a full rupture versus are we just having tendonitis, right? And so that is a component to all of this, right? Is what is the extent of the injury? Because that's going to dictate the time course of what's happening there. So our last connective tissue that we're going to talk about in terms of the healing, right, is nerves. They don't regenerate immediately after injury, right? And the regeneration can take place within that nerve fiber itself. Nerve injuries are very, very slow process, right? And so that rate of healing is an important kind of bullet point on this, in that we only gain 3 to 4 millimeters per day in that healing process. So if we get, start thinking about when we get that stinger injury in our neck, right, with a football player, 3 to 4 millimeters is not very far, right? And so it takes a long time to heal from a nerve-related injury. It does not heal quickly. When we talk about central nervous system nerves, so these would be nerves located spinal cord, right, and up into the brain, they don't even come close to being as fast as ones that, when we have nerve injuries in our arm or our leg, low back, wherever the case may be. And so nerve injuries do take a long time. And in terms of the overall process, these are definitely the ones that take the longest. And it's probably some of the ones that most people, when they have a nerve injury, it's the most, or one of the harder ones to work with, because you feel like you should be able to do more than you can, right? And it's that very slow process. So there are, like we said, various issues with each one of these, right? Whether that's blood supply, whether that is the rate at which tissues can heal, whether that is age. So there's some things that we can do to modify, right, the soft tissue healing process. There are other things that we cannot do, right? Age, no modification to that. Older people takes longer, right? Cartilage, lack of blood supply, takes longer. We have to take a different approach than with a ligament or a muscle or a tendon. Like we said, nerves just inherently take longer. So there are some modifiable things that we can do through diet, that we can do through, exercise. But again, getting to the whole premise of this, it is a time course, right? And every tissue is going to have a different time course as we work through that. So again, kind of bigger general concepts rather than minute details in terms of future questions or anything like that. Really looking for, can you delineate what would be specific factors that are modifiable and what are factors that are non-modifiable when it comes to injury and our return to it from injury. So the last little bit to this lecture or this video, right? We're talking about bone healing. Bone is different than our other tissues that we talked about. So fractures go through a kind of 5-stage process that's different than our soft tissues, right? The soft tissues, we have the inflammation, the fibroblastic repair, and our maturation and remodeling. Here we go through a little less complex process, and it's just one phase into the next, right? And so when we have a fracture, we're going to see our hematoma form, right? We're going to see a soft callus or in new blood vessels form, right? Spongy bone, and then we get these harder calcifications and the remodeling of that bone. And so when we break a bone, it's the same idea. Early stages, we're looking to protect, we immobilize, we allow these first couple things to happen, right? And then as it progresses and we start to see the hard callus and the ossification and that remodeling, we can start loading the bone to a greater extent. And depending again on the bone itself that is injured and how much load is placed on that bone is the timeline, right? So if we were to have a fracture in our fibula versus our tibia in the shin, they'd be different timelines. Even though they're located both in the shin, the fibula does not have the weight bearing that the tibia does. So we could probably have a little bit more or a quicker timeline on a fibular fracture than a tibia fracture. And so that difference right there, even though they're going to go through the same process, it's in the same location, can change our timeline to an extent. So when we have our fractures, and we talked about this in the last idea with the mechanism of injuries, right? Immobilization, you need to take x-rays. When we look at x-rays, we can start to see where we're at in that process of healing. We can have limited participation for a couple weeks. It could be months, again, all depending upon the location, the type of fracture, and which bone itself did get fractured or broken, right? And so because when we deal with fractures, there are some risk associated with that. We have to make sure that things like infection, the bone being set back into the right spot, making sure that we get adequate blood supply, that blood vessels haven't been severely damaged. Those are all important things that can change our healing process. So bone may actually die with poor blood supply, right? And so this is there are specific areas of bones when we do see fractures that we get very kind of worried about it. So things like the head of the femur, the navicular, and the wrist, all really important. When we start to think about the immobilization, right, or poor immobilization, so when we have bad casting, when it doesn't get set properly, how those bones come together and they form, and we see the new calcifications, and we see how those hard calluses are present, right? That can run into issues on how that bone specifically, and the joints around that bone end up functioning in the long run, and what we're capable of doing. So there are some acute management things that we have to be cognizant of. And again, when it comes to the fractures, we typically want to leave this to our medical professionals, but just kind of being aware, if you ever were to stumble across one of your athletes having a fracture, what are some of the things I need to be careful of in the immediate care of that, to make sure that we don't run into any future problems, right? And so with that wraps up our discussion on the tissue response to injury. If you have any questions, please let me know. I'll be more than happy to answer those for you.